Hi everyone, thanks for joining the National Headache Foundation and today's presentation on what can be done when my usual migraine therapy doesn't work. I want to thank Dr. Ira Turner for joining us today. Dr. Turner started the Center for Headache Care and Research at Island Neurological Associates in 2000. Research studies worked at have included multiple clinical trials on treatment of episodic and chronic migraine, as well as disability associated with those conditions. We want to thank him for joining us, and take it away.
Thank you, Eric, and thank you all for listening in. You know, those of us who have migraine, and I have migraine myself, had our lives changed dramatically in the early 90s with the advent of a group of medications called triptans. For the majority of us with migraine, these turned out to be extremely effective and extremely safe and well tolerated. But like any other treatment, if you just don't take it early enough, or if you woke up in the middle of the night with an unusually severe one and it was perhaps at that time accompanied by nausea and vomiting, perhaps your usual pill didn't work. So what do you do? These are my disclosures. The only ones of relevance to this presentation would be that I have given similar presentations at meetings of the American Headache Society and the Headache Cooperative of New England, but all of the others are just financial disclosures regarding research and consulting fees. So let's start with a case report. Lena is a 32-year-old female patient of mine who has a history of migraine without aura since age 16. Almost all the time, her symptoms would resolve pretty quickly with oral sumatriptan, or occasionally she might need to inject herself subcutaneously when she had a lot of nausea and vomiting, sometimes waking her up in the middle of the night, or occasionally she would use this as a rescue therapy when the oral sumatriptan didn't work. But this time she calls with a history that she had 3 days of headache that just did not respond to her usual treatment. She had gone to the emergency room the day before and had been treated with a medicine for her nausea as well as a narcotic. She was discharged after she had a non-contrast CAT scan that was normal, and she did improve a little bit with that treatment. However, 2 hours after that treatment, when she was already home, the headaches recurred and were more severe with severe nausea and vomiting. She was unable to sleep that entire night and called us first thing in the morning with the question, what to do. Sorry, that's not Lena, that's Lulu. That's another patient of mine who just doesn't pay any attention to what I say and always winds up laying on her rock in the sun. Lulu, get into the shade, you'll feel a lot better. So what are the options that we have for Lena? Well, we could do nothing, just wait for it to end, but that's obviously not acceptable. She's already had 3 days where she was unable to work or take care of household and social activities. Could retry the prior treatment, but why do that if it's already failed? When I mentioned the possibility of going back to the ER, I got the response, I hate the ER. And by the way, that's not a rare response that we get from patients who have migraine. And we'll talk a little bit more about that later. So I suggest to come into the office that we'd either do nerve blocks or give her some medications intravenously in our infusion suite. Of course, her response was, I'm on the way. So this is the treatment that we gave her. Our nurses referred to this combination of medications or cocktail as a full MONTY, which they think is very humorous, and most of the patients laugh when they hear that they're going to get a full MONTY. What we usually do with this combination, and we don't do this on every patient because it depends on what other medical issues they might have, but Lena got a ketorolac, the brand name of that is Toradol, 30 milligrams given intravenously. This was then followed by diphenhydramine or Benadryl and metoclopramide or Reglan. Diphenhydramine is an antihistamine and metoclopramide is an anti-nausea medication. These were both also given intravenously by our nurse. When these were in and the patient settled down into her reclining chair, she was then given intravenous magnesium sulfate over about 30 minutes. Sometimes we do it even a little faster than that. And this was then followed by a slow intravenous drip of dexamethasone, a steroid. And we'll go over some of the evidence for how this works a little bit later. But about an hour and a half after Lena came into the office, she was pain-free. There was no nausea and vomiting. There was no light or noise sensitivity. She was not drowsy at all. And some of these medicines sometimes do cause drowsiness, which is why I mentioned it. She had no abdominal pain. One of the things that concerned us when we started doing this several years ago is the combination of a non-steroidal medication like ketorolac plus a steroid, dexamethasone. This combination theoretically might cause some severe abdominal pain or even bleeding, but in all the years that we've been doing it, we've never had even one case of abdominal pain or bleeding from it. And she felt so good afterwards, she was able to drive herself home. Next morning, a follow-up call, she was totally symptom-free and going to work. So while this is not 100% of what happens all the time, this is a very common scenario of what we see for somebody who otherwise had been refractory to the usual treatment. So why do patients hate going to the emergency room? Well, number one, they almost always have a long wait in most emergency rooms. And then they're put into a room where they're waiting, where it's bright and noisy, and there's very often some intense odors. And one of the biggest complaints that we hear from our patients is they treat me like I'm a drug seeker, and then they give me narcotics. Well, you know, this would be almost funny if it wasn't sad and counterproductive. Because what winds up happening is, yes, narcotics do give a little bit of temporary relief to some of these patients. But as soon as they start to feel better, they get sent home, and they're just told that they should follow up with their doctor. Commonly, a few hours after that, the pain is back, and it's often worse than before, and they're even more refractory to treatment. And patients do learn this after a while. The unfortunate thing is sometimes they have no other option. Interestingly, there are 4 studies that have been done over the past 20 years on emergency room treatment of migraine. And in spite of the fact that we now have some very specific migraine medications that can be given by various injections, in all 4 of these studies over this 20-year period, opiates are still the primary treatment used in emergency rooms for migraine, in spite of the data suggesting that they really don't work that great and make patients refractory to other treatments. What's the average cost? At least on Long Island where I practice, and I've heard this from several of my patients who wind up in emergency rooms, every time they go, they wind up with a bill for over $2,000, which hopefully their insurance is going to cover a big chunk of. Very often they've been subjected to another CT scan, which in most cases is unnecessary radiation. Sometimes they even are subjected to spinal taps, which may or may not be indicated. And mostly they're waiting, and it's expensive. In our infusion suite, the typical cost is somewhere between $250 and $400, depending on how long they're there and what medications are needed. So there's a huge cost saving for patients and even for their insurance companies. So what works? Amy Goldfand and Peter Goldsby published a nice review article in 2012, and they summarized a lot of the data that was available from various studies of varying quality. And here are some of their conclusions. Hydration is very important. Many of these patients, after they've had a day or two of headache where they're really nauseated and often vomiting, they get dehydrated. And sometimes just putting an IV in and giving hydration is enough in some patients to start improving. They found that opioids are less effective, and they, of course, impair the effectiveness of more migraine-specific medications. And there's more and more data suggesting that migraine patients who use opiates are at higher risk for transforming from episodic migraine to chronic migraine, where they have more days with headache than without. Some of the medicines used for nausea, antidopaminergics, are extremely useful. And fortunately, they are being used in emergency rooms, and we use them extensively in our office. Triptans, particularly injectable sumatriptan, given subcutaneously under the skin, is extremely useful. And some of the triptan nasal sprays may also be useful as well. The reason these are more useful than something by mouth is that when someone's had a migraine that's really severe, especially if there's nausea, very often the stomach is not emptying. So if you take a pill, it has no place to go. These pills don't get absorbed in the stomach. They have to get out of the stomach into the small intestine. So sometimes bypassing the gut is the best way for these people to be treated. An ergot called dihydroergotamine is also very useful when used intravenously. This has been around for a long time. Before triptans, ergots were the mainstay of treatment for people with severe migraine. The problem with ergots is that they cause a lot of nausea and vomiting and have some potential vascular and other complications in some patients. But they are very efficacious when used appropriately. So what else works? Well, nonsteroidals given intravenously are very useful. There's lots of data on aspirin intravenously, which is used quite a bit in Europe but is not available in the US. Ketorolac or Toradol, which is what we use quite a bit, has lots of good data behind it. Another medication used intravenously, the sodium valproate, can be useful in some cases, but the evidence is not that strong. Corticosteroids, very similar to cortisone preparations, are often useful in reducing recurrence, but the data on knocking the migraine out is at best contradictory and not that strong. Magnesium, again given intravenously, anecdotally, we often find that it helps patients, but the data supporting its use is not that great, but it's a fairly harmless treatment for most patients. So what are the options we have? These next few slides are going to go through what the level of evidence is. The American Academy of Neurology and the American Headache Society have graded a lot of these medications according to efficacy. Well, level A is the highest, B is the second highest, C means that there's some evidence it works, and U means that we don't have any really good evidence one way or the other. Looking at the nonsteroidals that we have available to us, Ketorolac, given intravenously, has level B evidence. In the antihistamines, diphenhydramine, which we use quite a bit, does not have much evidence that it actually by itself will knock out a migraine. In fact, we don't really use it to knock out the migraine. We use it to reduce the side effects of the next group of medicines called antiemetics, of which two of them have level B evidence. Metoclopramide is the one we use the most. The third one is very good for nausea, but the evidence for on the migraine itself is lacking. That's ondansetron. Magnesium sulfate has level B evidence, although this is still somewhat controversial, but it is a very, very harmless treatment, and we use this quite a bit in our patients. As I mentioned, steroids have level C evidence. That means there's a little evidence of efficacy, but they're really most useful for reducing recurrence, and dexamethasone is the one we use primarily in our office. Occasionally, in somebody who's really bad, we may even use a very high dose of methylprednisolone, 1,000 milligrams given intravenously. I got the idea for using this for some of our really refractory patients from my partner, Steve Newman, who's an MS specialist. When they have an MS attack, they'll bring patients into our infusion suite and give them 3 days of intravenous methylprednisolone at this dosage, and it's very well tolerated by most. And anecdotally, he told me that a few of them who have migraines during their MS attacks, very often the migraine goes away as soon as they start the methylprednisolone. So I've used this on a few patients who are really, really bad, and have had some good results, but the level of evidence is not there. The only one that we have level A evidence for is injectable sumatriptan, which in most cases is the gold standard. This is the most effective medication for relief of an acute migraine. It's given subcutaneously, not intravenously. The problem with it is you can't use it if people have used another triptan or ergot within 24 hours. And also, very often the patients who come in to see us may have already tried this and it just didn't work for them, at least not this time. As I mentioned, the ergots have some good evidence behind it. These are mostly older medicines, so there are no new studies, but at least dihydroergotamine has level B evidence, which is fairly strong. Sodium valproate that I mentioned before, this is something we often add on people who don't respond quickly to the usual cocktail that I like to use. And we've had some pretty good results, but none of these things work for everybody. Surprisingly, giving intravenous caffeine actually is quite effective for some of these patients, and it's extremely effective, we found, in patients who have headaches due to low pressure. For example, after a spinal tap or spinal anesthesia, some people may get days of headaches every time they stand up. And we found that caffeine sodium benzoate given intravenously is extremely effective for the majority of these patients. So how do we rate improvement? When we do an acute migraine trial, I know many people are familiar with the 10-point pain scale. We tend in migraine trials to use a 4-point scale where 0 is no pain, mild is 1 pain, moderate is 2, and severe is 3. This is, in my opinion, an easier to use scale, and patients understand this quite well. So what we do is we have a questionnaire that we've used on all our patients for several years, measuring severity when they come in, and then we repeat it as they're about to leave. The overwhelming majority of patients who come in for this type of treatment have moderate or severe pain. If it was mild pain, they wouldn't be coming into the office to be treated. And this is what our results look like. This is 2 years worth of data. And we just presented this at the American Headache Society annual meeting in San Diego in June. Over this 2-year period, from November 2013 through the end of October 2015, we did 346 treatments in our office. The average pain scale to start was 2.6 on a maximum of 3. And when they left, the average pain scale was under 1, or mild, no pain. Nausea, we also, and sensitivity to light and noise, we also measured the same way. And as you can see across the board, not just the pain, but the other migraine-associated symptoms overall improved. Now, when you ask patients how they have felt at the end, whether they were improved, unchanged, or worse, 95%, as you can see below, felt improved. About 5% felt unchanged. And 1/10 of 1%, or close to 0, felt worse. That was one patient out of all the patients we treated. Side effect. Well, the most common side effect, which is not unexpected because we do use some medications that can cause drowsiness, was drowsiness. The second most common, akathisias, which is this form of restlessness that people get very commonly with some of the medicines used for nausea. When patients get this, they just literally can't sit still. They want to get up, they want to walk around. And that's one of the reasons why we give diphenhydramine or Benadryl in addition to this. We've reduced the incidence of akathisias down to about 7%. Back 4 or 5 years ago when we first started doing it, the incidence was more like 20, somewhere between 20 and 25%. So this is a pretty effective way of reducing this. But some patients really find this an annoyance, and it's one of the few areas that patients complain about when they get these treatments. Increased nausea in a tiny percentage. Insomnia can occur in some, and that's mostly from the steroids. Steroids certainly can have insomnia as a side effect. So those who do get steroids will occasionally complain of that. And as you can see here, with over 350-something treatments, we had no incidence of abdominal pain or bleeding from the gastrointestinal tract as we were feared. So, even though this sounds like there's some risk in doing, a combination of a non-steroidal and a steroid, we've had no incidence of this at all. Hopefully, this is quite common. We've been very lucky, I guess. What are the advantages over the emergency room? Well, one, rapid evaluation and treatment. We can actually, when a patient calls up who we know and they say, hey, look, I've had a headache for 2 or 3 days, it's not breaking, can I come in for IV therapy? We can give them a time to come in so they're not sitting there for 5 or 6 hours like they would in an emergency room. If they call at 9 o'clock and our nurses say, look, come in at about 11 o'clock, I'll have a free chair at that time. It works out much better. They get rapidly evaluated by a nursing staff and by either a physician or physician's assistant. We can control sensory stimulation by dimming lights, reducing sound, and we try to keep odors by avoiding patients coming in wearing perfume. It's very comfortable. They sit in a reclining chair. Medical records are readily available. We can customize the treatment according to what other medical conditions the patient has. And the cost is a fraction of what it would be in an emergency room. Disadvantages. There are always going to be disadvantages. One, you have to really be prepared. There can be unexpected medication reactions, which fortunately don't occur very commonly, but you have to always be prepared to treat allergic reactions and similar things. And you have to have a well-trained nursing staff. And to me, this is the most important thing. We could not do this without our really skilled and really caring nursing staff. The other disadvantages, will they be able to drive home or not after this? A lot of patients somehow manage to drive. My own personal bias is I think it's safer to drive home after treatment than when they're in the middle of a real whopping migraine. So we encourage people to have somebody drive them and somebody pick them up. But commonly, patients do drive themselves. The majority can be driven home. Our nurses are very good judges of who's capable of driving and who isn't. But if not, we could always call a taxi for them or call somebody to pick them up and drive them home and take their car back later. Another disadvantage is you have to have medications available and stocked. This is some expense for the practice. So a lot of people who are in solo practice might find this to be prohibitive. But for a large practice like ours, it's really not that big of an issue. And the other disadvantage, this is not meant for unknown patients. People can't walk in off the street who you've never seen and get this treatment. They have to be people who we know or a referring physician who's knowledgeable about migraine can give us some information about and give us some history and so we know what to expect. But it's not for people who are strangers walking in off the street. And the other disadvantage is that the evidence base for this is not that great. There aren't a lot of really good randomized double-blind placebo-controlled studies documenting efficacy. So it's mainly experience-based. And that's our staff, our nursing staff. They are the stars of our infusion suite. Kristen on the left and Tracy on the right. Kristen has had many years of home IV infusion therapy experience before she joined us a while back. And Tracy has years of critical care experience working in hospital ICUs and coronary care units and in radiological suites. So they're really skilled, they're really smart, and we really rely on them. And the patients love them. So when is the emergency room appropriate? We often, when we're teaching medical students about what are the red flags, we use the mnemonic SNOOP. Now, not all of these require somebody go into the emergency room, but the first few might. For example, if someone has systemic symptoms with a headache, for example, a fever, that patient should go into the emergency room and be evaluated. They should not be coming to an office. If they have focal neurological symptoms, or they're confused, or there's something that's changing their neurological status, that does require emergency evaluation. If there's a sudden, abrupt, or what we call thunderclap onset to the headache, somebody says, this headache is different than my usual migraines. It feels like somebody walked up and hit me in the head with a hammer. That patient needs to be evaluated in an emergency room setting. Now the last two, the older and the previous headaches that have now changed, those may or may not require an emergency room setting. Sometimes they can be worked up as an outpatient. Just remember these red flags and SNOOP. Or as they say down south, you could add a Y at the end and call it Snoopy because you all have no idea what's going on. That also might require an emergency room. And again, this is our 2-year results. It's very well tolerated by patients. We get really good results, and I think primarily because of the way we're set up to do this and our great nursing care. And of course, we want patients to feel a lot better after treatment than they did before. So if you have any questions, Eric, why don't we throw it open?
Yes, I do have a couple questions sent in. First off, one second, pull it up. Let's see. First question I have is it helpful to take supplements containing magnesium, vitamins B, D, and E? Can that be helpful for some people?
Well, it's not going to help you in an acute situation, taking those things orally, but there's at least a little bit of evidence that taking those on a regular basis might reduce headache frequency and severity. The data is not the strongest data, but certainly it's pretty harmless for most patients to use that combination.
And I'm not sure if you know the answer to this, but someone was wondering if you know of a similar center to yours in other areas of the country, specifically Boston. She says it sounds like something that she'd be very interested in.
I'm not quite sure. I know that there are several headache centers in the Boston area, several excellent headache practitioners in that area. So what I would suggest that whoever it is might just want to contact one of the headache specialists in or around Boston. There are really several of them, so I don't know how well they're set up to do this type of therapy. I know in Connecticut, Pete McAllister has got a pretty good setup, similar to he's in Stamford, and I believe that they're in Hartford area. There's one also. And there are several of them scattered around the country. Unfortunately, there is a lot of startup expense in starting a center like this. I was in the position, though, where I've got partners who have other subspecialties in neurology who already were using this, so for example, for MS or for certain inflammatory neuropathies. So in a 7-person practice, it's a lot easier to handle the expense of this type of a setup.
Great. David asks, any suggestion on how often to take Relpax if daily migraines occur?
Well, all of the triptans, not just Relpax, but all of the triptans, we don't like people to take them more than 10 days per month. And the reason why is that if you exceed that amount, there's a good chance that you will increase the chance of medication overuse headaches and transformation to chronic migraine. I've heard people say not to use them more than 2 per week. That's okay. That's reasonable. On the other hand, if somebody uses 4 in a week and none the rest of the month, that's okay also. So it's generally somewhere around 10 doses a month that we don't want patients to exceed with any of the triptans, not just Relpax. They all have basically the same concern.
Okay. Someone asked, is vertigo considered a symptom of headache, as her neurologist told her?
Well, vertigo is not by any means uncommon as a symptom of migraine. It's not one of the classic migraine symptoms as recognized by the International Headache Society and their criteria, but certainly vertigo does occur during migraine, and there are some people, and there's some data to back this up, who think that migraine is the second most common cause of vertigo after an inner ear problem.
Great. Another question coming in. If gabapentin becomes ineffective after years of taking it, what is the proper way to gradually wean yourself off of it?
Well, a lot depends on how long the patient was on it and how high the dosage was. I generally like to do any of these medications, and people have been on for a long time. I like to taper them off over anywhere from 2 to 6 weeks, depending on the medication and depending on how high of a dose and how long they're on it. So there's no one answer to that. It's very dose dependent and duration dependent, but it's always better to do it slowly.
And then this one, I don't have a lot of specifics on it, but maybe you can just touch on it. She asked you to mention, maybe discuss a little bit about migraine seizures. There's no specifics, but I don't know if there's maybe something along the content of this discussion that might be relevant.
Well, it's actually quite uncommon to see somebody have a seizure during a migraine. On the other hand, patients with migraine have a higher incidence of seizures than the general population, and patients with epilepsy have a higher incidence of migraine than people who don't have epilepsy. It doesn't mean one necessarily causes the other. The concept of a disorder called migralepsy, where somebody has a seizure as part of their migraine, is very interesting. I think in the 40 years I've been in practice, I may have seen one case like that, but it's quite rare, actually.
We have a question from John. He says, how can someone using triptans 15 days a month break the cycle and stop the recurrence?
Okay. Triptan medication overuse is very easy to break. You just stop it because you don't get withdrawal symptoms. It's not like you're overusing an opiate or a barbiturate. Okay, so it's pretty easy to break triptan overuse. The problem is that, of course, you're still going to have a lot of headaches. If they're using 15 days per month, I suspect they have headaches way more days than that. So the critical thing is to break the cycle, and sometimes we'll bring them into the infusion suite to do that for a day. But getting them on an effective migraine preventive medication is absolutely critical. And unfortunately, that does entail trial and error. The other, besides coming into the infusion suite that you could break a cycle like that and give some temporary relief, is by doing nerve blocks. We often do occipital nerve blocks, trigeminal branch nerve blocks, and sphenopalatine ganglion blocks right in the office. Very easy to do it. As a matter of fact, my physician's assistant is one of the most skilled people at doing that. I actually readily admit she's better than I am at doing those procedures.
Okay. Then we have 3 more questions, and then we'll let you go. Is that someone? Janet asks, is it normal to have to stay on preventative medications like Topamax while receiving Botox injections for chronic migraines?
It's not wrong to do that. I very often have people on a combination, but don't forget the reason we're probably going to treat somebody with Botox is because whatever they were on, whether it was Topamax or something else, didn't work that great. Now, on the other hand, if Topamax did help some but not enough, it doesn't hurt to leave somebody on it as long as they're tolerating it well. I've got a lot of people on a combination of the two. But let's say 3-4 months down the road, they're really doing well on Botox. It's reasonable at that point to start tapering them off at Topamax.
Okay, 2 more. This question is from Diane. She asks, how do you break the cycle for new daily persistent headache that has lasted daily for 17 months?
Good luck. The unfortunate thing is, first of all, new daily persistent headache is not the same as migraine or chronic migraine, although the headache itself could have migrainous features. The unfortunate thing is, at this time, we have no very effective treatment for new daily persistent headache. It'd be very nice if we had clinical trials ongoing to a large degree to see if any of our current migraine treatments would work. But what we often do is we wind up trying many of the medicines we use for migraine on these patients. And sometimes you can get some temporary relief in these patients with nerve blocks. Sometimes some of the medicines we use like Topamax are effective. But unfortunately, new daily persistent headache is perhaps the most refractory headache disorder that we encountered in this time.
Okay, last one. Where'd it go? Do you have any recommendations for someone with medication overuse headache from opiates who does not respond well to injections?
Well, the most important thing about people who are getting opiates is to get them off of it. There are a lot of things that we could try. If somebody's using a lot of opiates, I often try to enlist the help of a detox specialist in the area to help them, particularly if they're using them on a daily basis. But most of the other stuff, it's much more difficult for them to work unless unless they get off of the opiates. So, cutting back on the opiates and introducing migraine preventive therapy is the best way to go. I hope I answered that question. Was that clear?
It was to me. I think we're okay. I want to say, I know people are still sending questions. We do have to let Dr. Turner go, and we have our webinar service. It cuts off after a certain amount of time. But I want to let everyone know, if you have any questions, you can always email us at info@headaches.org, and we'll be happy to pass these on to Dr. Turner or any of our other physician headache care provider board members, and see if they can help you out with it, or at least point you in the right direction. So even if we weren't able to answer your question right now, please feel free to send us an email, and we'll try to help you. So I want to thank you again. Yes.
Yeah, just one other thing that there was a question about someone near the Boston area who might be useful. While we were doing this, I just noticed I got a text message. One of my colleagues, Shivang Joshi, who is, I think he's in Westboro, just outside of Boston, does do intravenous therapy at his office. I believe, and he also has a practice just outside of Providence, Rhode Island. Plus, there's the the John Graham Headache Center at the Fortnett Hospital, where I believe they do some intravenous therapy there as well. So as we were talking, I started getting a few text messages that I happened to notice on my phone.
Great. All right. Well, thank you again for your presentation and your time. Hopefully, it helped a few people out. And if you still have any other questions, feel free to email us, and we'll try to get you an answer. All right, everyone. Have a good night.
Okay. Thank you.
Thanks.